Hello and welcome back to this, my Carbidopa sofa. If you caught our last video, we discussed the parts and systems of the body which Parkinson's disease, or PD, affects, as well as how those changes showed themselves symptomatically. Since we now have at least a basic understanding on what is happening within the body, we can start to discuss how it is that we try to fix those issues. In medicine, we have multiple avenues that we can use in providing care for patients. We can do it pharmacologically, with medications via pharmaceuticals, or non-pharmacologically through physical therapy, surgery, diet, exercise, and other non-medication related methods. Pharmacologically derives shockingly from the term pharmacology, which means the study of drugs, including their origin, composition, pharmacokinetics, therapeutic use, and toxicology. Sadly, delving more intimately into all that pharmacology entails will need to be saved for another video. But let me just say that personally, it's my favorite aspect of medicine. But I digress. Let's begin by discussing the more common pharmacological therapies that one might see when being treated for PD. I must note that this is not a recommendation for therapy, nor is it a checklist for what your physician may or may not prescribe for you or a patient. Rather, this is a brief overview of possible therapies that might be seen. When we discuss therapies, we will try to always explain how that drug works, which we call its mechanism. We'll also try to explain the effects it might cause, often called side effects, as well as any pertinent information we feel you should know. First off, we'll talk about the namesake of this channel, a combination medication including two things, carbidopa and levodopa. It's branded under the name Sinemet. Levodopa we will refer to as L-Dopa for short. L-Dopa is what actively helps replace dopamine in the brain. The reason we don't just give oral dopamine is dopamine can't pass the blood-brain barrier. That's something that you can think of as like a filter, which stops some substances in the blood from getting inside of the brain. L-Dopa is actively converted to dopamine in the body, which can cause other effects, side effects. To get into the brain, we need to trick the enzymes that convert L-Dopa, thus enter carbidopa. Carbidopa looks very much like L-Dopa, and when it is picked up, it inhibits those enzymes that create dopamine from L-Dopa. This greatly improves what we call the efficacy, which is the efficiency of the drug, L-Dopa. L-Dopa's half-life, or the time it takes for 50% of the drug to be removed from the system, goes up from 50 minutes to about an hour and a half. Carbidopa's reduction of L-Dopa's conversion outside of the brain also helps limit L-Dopa's adverse effects. Those are those side effects we talked about, of which many are related to this early conversion of L-Dopa. Some of the more common side effects include dyskinesias and nausea and vomiting. Dyskinesias, going back to our favorite things, Greek words, is Greek from dys, meaning bad or abnormal, and kinesis, meaning movement. This manifests as flowing, dance-like involuntary movements, usually involving more of the body in contrast to PD's rhythmic tremors we discussed in the last video. Dyskinesias can be caused by excessive dopamine stimulation. It should be noted that dosing may need to be adjusted to your response to Sinemet. Dose adjustments with Sinemet can happen a lot, so that should be an identified thing in your therapy. Duopa is a newer form of carbidopa-levodopa that is used through a pump directly into the intestine, and it's found to lessen some of L-Dopa's related dyskinesias. We will see the side effects of low blood pressure, hallucinations, and sleep disturbance come up between multiple medications used for PD. This is due to most of them all working in similar ways. Dopamine affects many systems of the body. Thus, whether we are increasing or decreasing dopamine's activity, we will see changes in multiple systems. Hallucinations alone can affect about 40% of PD patients, especially in the later stages of the disease.
As we begin to look more and more into drugs, we will see the word agonist and antagonist appear more. Agonists are activators. They bind to a receptor just as a receptor substrate or target molecule would. Antagonists, on the other hand, are inactivators. They directly or indirectly bind a receptor, making it unable to accept its regular target. Now that we know what an agonist is, we know what this next class does. Dopamine agonists bind dopamine receptors, stimulating these receptors in the brain. The main ones you'll see are pramipexole, also called Mirapex, and ropinirole, also called Requip. These two help limit the effects of the disease stemming from loss of dopamine activity. Dopamine agonists, as they similarly affect dopamine, have similar side effects as L-Dopa, but uniquely we see sleep attacks, peripheral edema, and impulse control disorders. Sleep attacks are sudden onsets of sleep occurring up to 1 year following start. Impulse control disorders are described as a possible increase in risky behaviors such as gambling and other impulse behaviors. These can be seen with increased dopamine activity. Dopamine plays an integral role in reward and anticipation. By activating these receptors, we also intensify the impulse response. Patients on dopamine have been observed to participate more commonly in impulse gambling and shopping. I went to a Parkinson's disease convention once in a casino. It didn't strike me as the best choice in venue for such an event. Decreasing the dose has been found to help decrease impulse behavior, but not decrease sleep attacks.
Now we'll discuss COMT inhibitors and monoamine oxidase B inhibitors. These medications work towards the same basic goal, utilizing different paths to do so. As L-Dopa is broken down rather readily, half of the battle of getting into the brain is making sure it is not broken down by the time it gets there, let alone ensuring it doesn't get broken down immediately after making it into the brain either. COMT and MAO-B are such enzymes that break down L-Dopa and dopamine. Two common COMT inhibitors are entacapone and tolcapone. Side effects manifest with similar dyskinesias as dopaminergic medications with nausea and vomiting, and diarrhea. All of these can be correlated to the decreased removal of dopamine, with differences dependent on the central nervous system versus the peripheral nervous system. The more prominent monoamine oxidase B inhibitors are selegiline and rasagiline. These agents are more specific for CNS activity than COMT inhibitors in stopping the breakdown of dopamine. Side effects are similar to COMT inhibitors with dyskinesias, nausea and vomiting, and headache as being common. Now we'll move on to anticholinergics. In an exceptionally oversimplified view, one can think of acetylcholine, another important neurotransmitter, to be the foil of dopamine in Parkinson's disease. So, anticholinergics help limit acetylcholine, which provides a benefit with tremor and rigidity. Trihexyphenidyl and benztropine are two examples that can be used. Anticholinergic side effects are rather notorious in the world of pharmacy. So notorious that it has a memory device behind, which I will share with you. Hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. This artistically describes the possibility of dry mouth, sedation, confusion, constipation or urine retention, flushed skin, and blurred vision.
Besides pharmacological therapy, there are a host of paths that can be taken to help with the progression of PD that aren't related to pharmacy. They include physical therapy, specifically what are known as big and loud exercises. These follow well-researched intensive regimens which help patients retrain sensory, motor, and cognitive functions. Often, PD patients' voices will become a little softer, and the loud side helps with this. And many will join singing groups for this purpose as well. Other PD-focused activities include water aerobics, cycling, and even a little boxing. One of the more intriguing therapies is DBS, or deep brain stimulation. This is a complex subject on its own, and hopefully we'll be able to dive deeper into it in the future. But for simplicity's sake, one can think of it as a pacemaker for the movement area of the brain. It helps control movement symptoms, which might not be controlled by medications alone, by electrically modulating the systems which determine motor control. There was a lot of info packed in this little video. Below, if you follow the link in the description to our website, we've made a TLDR, or too long, didn't read table of the common medications discussed. Feel free to keep it for your reference, and we'd love to hear from you down below in the comments. With that, thank you as always for watching this video, and we'll see you some other time.